The Honorable ladies and gentlemen, we are moving to the next agenda, which is the first plenary session under the topic of tuberculosis prevention.
All right, in this first plenary session, dear ladies and gentlemen, will be moderated by Professor Dr. Sri Rezeki Hadi Negoro. A brief introduction about Prof. Sri Rezeki Hadi Negoro. She is a pediatric professor at the Universitas Indonesia. She holds leadership roles like chair of the Indonesian Technical Advisory Group on Immunizations and membership in the National AEFI Committee. Her impactful research includes dengue vaccine efficacy and Streptococcus pneumoniae, and she has received notable awards such as Outstanding Asian Pediatrician 2012 and Lifetime Achievement Award from FKUI in 2014 for her contributions to medicine. It is now our pleasure to invite Professor Dr. Sri Rezeki Hadi Negoro.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, selamat pagi, sugeng enjang. Nice to meet you again in this plenary session for the INATIME. I am Sri Rezeki Hadi Negoro from University of Indonesia. As already mentioned, currently I chair for the ITAGI, and it's my pleasure to chair the first plenary session in the INATIME with the topic of TB prevention. Before I start the session, I invite the speakers, please come forward, sit here with me, Dr. Andaru and also Dr. Phillips. Please come forward. In this occasion, Professor Graham cannot come because it's very difficult to reach in Indonesia. Yes, please. Thank you. Yes, ladies and gentlemen, as reported by WHO and also Ministry of Health, that the increasing number of people with TB is mostly who are not detected by health services. And as a result, the number of TB in population and undiagnosed and untreated TB in the community. And second one is also a problem in MDR TB. And we will ask three speakers today on plenary session. And we'll talk about the TB prevention. I think it's very important and very interesting topic. They are Dr. Andaru Devi from University of Gajah Mada, We will talk about the tuberculosis infection prevention and control. And the second one will be Professor Graham Bottomley from the London School of Hygiene and Tropical Medicine in UK. We'll talk about the TB vaccine. And the last one, Dr. Phillips Alexander Ducrot with the topic of tuberculosis prevention and therapy. So ladies and gentlemen, we start for the first speaker, Dr. Andaru Dahesing Dewi. She is a medical doctor, clinical pathology specialist and consultant of infectious disease and microbiology. The current position are the staff in clinical pathology laboratory Dr. Sarjito Hospital, Universitas Gadjah Mada. She is also a head of medical committee in the same hospital and member of committee of antimicrobial resistant control belong to Ministry of Health. So in fact, your time is about 20 minutes, and the topic will be the tuberculosis infection, prevention and control. But it's maybe difficult, you sit here, because this slide is not appear. Yes. Ya, silakan. Bisa
Thank you very much, Prof. Sri Rezeki. I permission to be down. Excuse me. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, good morning for everybody, our honorable college, professors, seniors, TB researchers, and all college ladies and gentlemen. First of all, I would like to say thank you for the committee for the invitation and my opportunities to share our knowledge and experience in TB infection control. Slide. I think I would like to present our presentation divided into 4 subtopics. Slide. TB epidemiology in Indonesia, commitment for TB elimination, and the chilling of TB I see here in Indonesia, particularly in Yogyakarta and in my hospital, Sarjito Hospital, and my practical experience. Slide. Yes, Indonesia has risen to the 2nd rank of TB incidents after India. With an estimate of more than 900,000 active TB infection reported by WHO Global TB Report in 2022. Indonesia is recognized as one country with highest TB in global, in the world, yeah. And disruption due to pandemic COVID-19 in 2020, actually we has increasing active TB at about 17% and was predicted to slow down the achievement of target program of 5 to 8 years. But actually we still in 45% of detected and reported cases, and the rest isn't detected and reported yet. So it potential risk to be a source of transmission. Next slide. Actually, TB is transmitted through airborne route. expulsion droplets containing Mycobacterium tuberculosis, coughs or sneezed into air, remain suspended in air 1 or 2 hours, actually could be sterilized by sunrise and or dispersed with winds. But in the conditions like darkness and moisture, these infectious mycobacteria preserve to survive from hours to months and could be introduced to susceptible people, hosts, through inhalation and ingestion. Difference with COVID-19 that quickly spread and directly provide the clinical sign or symptoms as well as the positive test result. TB infection influenced by many conditions and take times to be manifest. So it decreased the awareness of people, community, even healthcare facilities in infection control. Practice infection control consistently. 3 factors determine TB transmission. First, the number of germs exposed to the air. That's influenced by source control. The second, concentration of germs in the air, influenced by room ventilation and room volume. And the third, the length of time someone breathes fresh air contaminated. Next. Yes, this slide shows the spectrum of the disease. We can see that there are people without symptoms, but without positive results, particularly in routine TB tests, such as sputum smear, but could be detected by, might be the tuberculin skin test or interferon gamma release assay. And it categorized as TB latent infection. In this scope, people at latent TB infection pose as the source of transmission again. Next. Risk factors for TB is the least 8 component or factors. Increasing risk to TB, HIV, immune suppressed disease, smoking, malnutrition, alcohol consumption, age less than 5 years old or elderly, close contact with active TB cases, being in place with a high risk of being infected with TB, and healthcare workers. Next. In the NTB strategy at glance 2016 to 2035, it mentioned a vision, goals, indicators, compare with 2015 achievement. That's reduction in number of TB deaths, reduction in TB incidence rate, as well as TB affected families facing catastrophic costs due to TB should be 0%. Next. And 6 pillars of Indonesia public-private mix or INATIME, the comprehensive model developed by NTB Indonesia based on the current challenges facing NTB and the strategic action plan. covers the hospital dose in public and private sector, basic dose services at primary health care, quality dose services by private practitioners and specialists, strengthen lab network to qualify TB diagnostic, as well as community system strengthening to TB infection and TB infection control and TB treatment. Next. This is the roadmap for TB elimination. Covers management for latent TB, screening in TB high-risk group, and expanding the reach of services to people with undetected TB in the community, expansion of molecular rapid tests, achieve high coverage of bacteriological confirmed diagnosis, and increase investment to the success of TB treatment. Next. Yes, we move to infection control principle that should be conducted by all with the leadership and strong organizational commitment for quality and safety of services, keep in regards to the cost effectiveness and sustainability. Next. This is the proven effective infection control strategies to achieve the zero tolerance for healthcare associated infection, including TB infection control. Next. Based on the hierarchy of control, TB infection control in healthcare facilities must strengthen the administrative measure, starting from initial screening for all patients in healthcare facilities as well as all visitors, followed by accurately or safely separation and speeding up the flow to the access of services. And then the SARS control could be conducted with fit PPE as well as proper the availability of standard PPE such as respirator N95, etc. And for environmental cleaning should monitor the effectiveness of environmental surveys, decontamination frequently and adequately. And then monitoring and surveillance of healthcare workers is the important task for provide the protection for healthcare providers. Next. Indonesia has national infection prevention and control guidelines for TB, MDR-TB as well as XDR-TB. There are 3 levels of policy. In national level, in healthcare facilities level, and policy in specific condition. Principally, there are 3 levels of hierarchy of infection prevention and control in TB IC program that are administrative control, environment control, and personal respiratory protection beside of managerial TB IPC measures. Our challenge is in consistently implementation in administrative TB IPC measure and environmental TB IPC measure. Administrative measure consisted of symptomatic screening, cough etiquette, separation and fast tracking, prompt diagnostic and treatment, staff training, and patient education. Well, whatever the environmental TB IPC measure, that's ventilation system, either natural, mechanical, filtration, air filtration system, and using UV germicidal irradiation. Next. Yes, we have Keputusan Dirjen Yankes with SOP IPC in healthcare facilities, and TBIC refers to WHO guidelines, and MOH conduct evaluation survey because of the realize if TBIC hasn't implemented consistently, it will impact the raising the transmission risk in healthcare facilities as well as in the community. Next. The resume of survey generate the improvement opportunity. In triage might be the opportunity to improve is in cough screening, communication, information, and education, as well as the separation of HIV services from TB services. Next. For environment measure, we have to strengthen the maintenance and routine inspection on natural ventilation, at least once a month or whenever the ventilation is felt to be poor. Next. And the PPE, the most challenge is that healthcare facilities isn't performs fit tests, so it's pose the healthcare workers at risk. Next. Guidance and supervision have been conducted by Dinas Kesehatan, and all the TB infection control, TB program is listed in accreditation standard, and for TB program as program nasional should be achieved targeted in 100%. Lanjut, next. Yeah, now we move to Sarjito Hospital. The teaching and referral hospital part of academic health system in Yogyakarta. We strengthen active finding, isolation precaution, education through multimodal strategy approach. We have tempo, temukan cepat, segera, kemudian pisahkan dengan aman, dan obati dengan tepat. Next. Yeah, for primary screening, we make sure that all visitors, all patients should wear masks, and followed by separation, all that as part of the droplet precaution as well as cough etiquette and respiratory hygiene. We have safety supervisor to monitor the compliance of implementation. Next. We practice the precaution, either standard or transmission-based precaution. Next. And for TB, next, we strengthen the droplet and airborne precaution. From triage, we do education, separation, make sure that masks available whereby all the visitors and patients use tissue to close the sneezing or coughing. Focus on getting the right patient to the right place at the right time with the right care provider. Next. For strengthen the administrative measure, we concern in separation and source control. Starting from primary screening, make sure all visitors using masks and implement hand hygiene, the secondary screening, we conduct the initial assessment with the list of questions, and then followed by either tests, laboratory tests or not, based on the screening result, and then the separation and patient placement, particularly based on the comprehensive assessment. Next. Yeah, this is the list of questions due in secondary screening. And notification of high-risk patient to TB infection, online shared directly, automatically to all division at hospital. And based on active case finding during first semester in 2023, we have 5.5% for positivity of drug susceptible TB based on the rapid molecular test. Next. Yeah. Strengthening environment measure, we make sure that all people aware the environmental factor increase risk for transmission and absolute needed to powerful environment or ventilation systems such as SGH, air dilution direction pattern, exposure to sunlight, yeah, and ventilation system. We arrange naturally, mechanically, or the combined hybrid. Next. Yeah, this is the program for administrative measure for healthcare workers. The challenge is it is limited data from surveillance among healthcare workers. Next. Yeah, but from current study conducted by Dr. Rina Triasih et al., we find TB infection among healthcare workers in 4 healthcare facilities, 1 hospital and 3 primary healthcare, at about 25%. Dominantly work in hospital, with median time working at healthcare sector was 13 years. With the risk, male work in hospital and older age, with adjusted odds ratio more than 1 significantly. So the researcher recommend to prioritize screening programs regularly if universal coverage of prevention and control measure cannot be achieved. Yes, and finally, as conclusion, next. Yes, next. All pillars measures should be implemented consistently at all levels of healthcare workers, personally or communally. We needed understanding and awareness of all of us, from leaders to individuals, to apply TBIC, carry out active detection and breakthrough in treatment. Okay, that's all. Thank you very much for the attention. Next. Yeah, thank you. Stay fit and stay healthy. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Andaru. Your presentation is very comprehensive one. Thank you for the presentation. And now we move to the second speaker, will be Professor Graham. Yeah, Professor Graham Botham Lee. He is come from Tropical disease hygiene and London School of Hygiene and Tropical Medicine. He is Bachelor in Physical Sciences in Medicine from the Oxford University. And after general medical training, she gained a PhD in the MRC, Tuberculosis and Related Infectious Disease Unit in Royal Postgraduate Medical School in Hammersmith Hospital for the monoclonal antibody diagnostic and also the pathophysiologic pathogenesis of TB. He completed higher medical training in the London Chest Hospital, and he has a consultant physician at the Hamilton University Hospital. She was appointed as a senior lecturer in 1995 and then a honorary professor in respiratory infection in 2010 in Queen Mary University in London. And he has a honorary professor from the London School of Tropical Medicine, Hygiene and Tropical Medicine in 2017. And current position from the Department on Infectious Biology, Faculty of Infectious and Tropical Disease, London School of Hygiene and Tropical Medicine, and also Blizzard Institute. We can see here, he also teaching for some modules and also courses in European area. So, because some reason, Professor Gaham cannot attending this very important Congress, but she sent the recording slides. So, may I have the slide from Professor Waterley? Bisa ditayangkan slide-nya?
Hello, my name's Graham Bothamley. I work mostly at the London School of Hygiene and Tropical Medicine, but also at the other institutions. And I'm very grateful to the organisers of this meeting to be able to talk to you about TB vaccines.
Sound-nya tolong dibesarkan.
So the plan of the talk is to look at BCG, to revise or tell you some basic immunology and how that's developed over the last 25 years, and then to look at TB vaccines and in particular the very large proposed trial for the M72 vaccine. The first question arises as to whether BCG, does it actually work? The initial trials in the UK under the MRC showed quite a significant efficacy, whereas the subsequent trial in Madras failed to document this. The first meta-analysis to investigate this was to look at primary compared to post-primary disease. And you can see that in these forms of disease, the risk reduction of likely TB after BCG vaccination was much lower than if other forms of TB were included. "20 years later, a further meta-analysis was designed to look particularly at pulmonary tuberculosis. And one of the key features was this risk of bias, because follow-up of people after tuberculosis, after vaccination, is really important. And you can see that not only do the confidence limits lie to the left so that BCG reduces the risk of pulmonary tuberculosis, but also this Tor squared value is also significantly different from 0. Much of the effect, though, was in terms of neonatal vaccination or in school childhood vaccination in those who were tuberculin negative. 2 other considerations were introduced into that paper, which I'll show some slides to, regarding latitude and strain of BCG. In terms of latitude, just to note that the Madras trial, that's Chengalpattu, and the one in Haiti, both of which are at the same latitude, were at opposite ends of the efficacy spectrum. With regard to the BCG strains, this is how BCG has evolved via various duplications and then loss of regions of difference, RD. The biggest trial in terms of BCG was in Madras and compared the Pasteur and Danish BCGs, and you can see that they're on very different trajectories. But it found no difference. So I think we can conclude that BCG is very effective against primary tuberculosis, but if you've met tuberculosis before, this affects your immune response and BCG is less effective. Now, just to move on to basic immunology, let's start with the immediate response. So this isn't pathogen or antigen specific, and in respiratory infections we've all seen that neutrophils tend to be high, CRP tends to be high, and these are part of the early response against all bacterial infections. These membrane-bound receptors can direct particular immune cells to the site of infection. Often they react to RNA or DNA found in viruses, and this induces an interferon alpha or beta type response, which then leads to inflammation. One of the curious features about BCG trials was that when they were given to neonates, not only was TB prevented, but there was a reduced mortality from sepsis and other respiratory infections. And hence the idea of a trained innate immunity, that your initial response was small, but subsequent infections you had a much quicker and greater response to any infection. I should note that infection with Mycobacterium tuberculosis itself, rather than BCG, doesn't cause this type of trained immunity. Most people think of immune responses in terms of antibody responses because they're most relevant for viral diseases. And you can see that in the primary response, mostly it's IgM antibody, and then a bit of IgG develops towards the later stages. But if you come across the same infection or the same antigen, you get a much quicker response, which is bigger and associated with more IgG. T-cell responses aren't really like that. There are very few longitudinal studies, so I've chosen this one with yellow fever to show what happens to the CD4 and CD8 cells. And you can see that after the first vaccination you get a CD4 response about 2 weeks afterwards, and similarly the CD8s are much greater. Now these aren't individuals, they're related to individual epitopes or very small bits of the yellow fever virus proteins. So when you get the second vaccination 18 months later, you get a much bigger response to CD4 by CD4 cells, but only in some. Other epitopes tend to remain low. And in terms of the CD8 response, really there isn't a secondary type response. Curiously, in terms of memory, 30 years later, you still get an early response, but you also return some to the later response. CD8 cells, however, their memory seems to be more consistent. Now, just historically, let's go back and look at BCG. Firstly, it was shown in mouse models that only live BCG provides protection. serum or antibody was of no benefit. And through depleting particular cell types, the CD4, the CD8, or transferring them from those vaccinated to another mouse, which was then challenged, you could see that both cells were important. And we know this in terms of human population, because in terms of HIV, if you have very low CD4 counts, then you're more likely to get disseminated forms of TB. This part reveals the mouse side of things in that they're much more protected against tuberculosis than humans, and it's only when you disrupt the molecule that presents antigen to CD8 cells that you get cavitation. Interferon gamma has always been thought to be important because of activating macrophages, but in terms of mutations, the forms of disease are not at all like human tuberculosis. There has been, in the 1990s, we had this type 1 response, which was cell-mediated immunity, compared to type 2, which is related to antibody production. Since that time, we've discovered that these really reflect different types of response. This is the pro-inflammatory type response, and then you have a tissue repair type of response when the infection is over. And in order to make sure that the inflammatory response is not too great, you have a type 3 now, which is a regulatory type of response. And you can see that these types are relevant to lots and lots of different cell types. For simplicity, we know that granulosin is the only substance known to kill tuberculosis directly, and I'll show the evidence in my next slide. But you can see that CD4 cells, CD8 cells, NK and NKT cells, and gamma delta cells all produce this peptide that is good at killing tubercle bacilli. So this is the classic experiment from 1998 in Science, showing that with saline that the tubercle bacilli looks quite normal, but if you add conditioned media containing granulosin, then you get these little blebs appearing in the tubercle bacillus, and when you look at them, they look as though they're puncturing holes in the cell wall, and this is a graphical representation of its effect on the number of cells. In terms of cytokines, often balance is the most important. And this is a study looking both at a zebrafish model of tuberculosis, but also at TB meningitis. And you can see that when TNF is too low, macrophages aren't activated and there's uncontrolled TB growth within the cell. But if the TNF is too high, then the macrophages die and there's more uncontrolled growth in the extracellular space. And in looking at what determines this sort of severity in TB meningitis, they showed that leukotrienes were effective, but it was the middle, this balanced response, that had the best outcome. And then lastly, I'll talk about immune imprinting, and this is where the first exposure to an antigen, whether by infection or vaccination, then dictates all subsequent responses to variant forms of that antigen. And this is why you have to have an influenza vaccine regularly every time a strain arises, because otherwise you would produce antibody only to the ones that you'd already met. It also explains why the recent trials on dengue resulted in more deaths, because they produced non-neutralizing antibodies to the different strains. And even in whooping cough, you get a good antibody response which reduces the severity for the person but doesn't affect transmission. is this important in BCG? Well, we know that BCG differs from Mycobacterium tuberculosis by this region of difference 1, which includes the ESAT6 and CFP10 antigens which are used in the interferon gamma response assay. So you can see that if you're exposed to BCG beforehand, then you may well not be able to respond to these two antigens when meeting tuberculosis. And so when we look at this trial which was undertaken in Indonesia, you can see naturally that exposure was significant as to whether you developed a positive EGRA, but BCG reduced the likelihood of having a positive EGRA. So this can be interpreted as reducing infection, but it may be just an example of immune imprinting. So in terms of immunology, firstly, the primary immune response is good at preventing disseminated disease, but usually you need a balanced and time-limited inflammation and repair to fight off TB. And when you look at T-cell memory, then it's variable in size and duration, and not at all like the primary and secondary antibody responses. So looking at TB vaccines, these have been divided into two types, preventative and therapeutic. In terms of prevention, BCG is acting as a pre-exposure type of vaccine where you prevent either infection or you prevent disease. Post-exposure means that there's evidence that you've been exposed to tuberculosis, but then you don't go on to develop disease. And that's the vast majority of individuals. Some therapeutic vaccinations have been proposed to shorten treatment or to make relapse less likely. So in terms of different types of vaccine, you can see that whole cells, live organisms, they're a bit like BCG. This one is attenuated Mycobacterium tuberculosis. It's removed the RD1 antigens, but then it also needed to remove something else in order to make sure that it really was attenuated. This vaccination uses Listeria lysine to try and provoke a more CD8 type response. Killed organisms have been used, and there are examples of these, but the difficulty has been getting a good enough immune response. And this becomes even more problematic when you only have one or two or a few MTB antigens. And therefore you need quite a significant adjuvant, such as this AS01E, in order to provoke an immune response. And just to talk a bit about adjuvants, these give you a non-specific increase in immunity, and most people started off using BCG, but just to mention that it's not used in any of the new vaccines. Again, antibody responses were preferred, and hence these type of adjuvants were used. But now we're trying to provoke a more Th1 and a Th17, which is a pro-inflammatory type of response to the antigens and the pathogen. So, just to mention this particular antigen, and the reason for including it is that there have been some successful trials in phase 2B, and a big trial is planned using this vaccine. What is the M72 antigen? It's a mixture of two antigens that were identified because they gave a good antibody response. They're also not secreted antigens, so they're found only in the cell wall and in sort of crushed bacteria. One's a serine proteinase and the other is, as I say, part of the cell wall. There have been concerns about these antigens, both of which show quite significant strain variation in different strains of tuberculosis. So it may not be effective depending on which strain of tuberculosis you come across. In terms of T-cell responses, they've looked at proliferation, which is IL-2, the interferon gamma, which, as I mentioned, activates macrophages, and this TNF response, which has to be quite balanced. And in mouse studies of challenging after vaccination, this single antigen reduces the number of tubercle bacilli by half a log, which by comparison BCG reduces it by 1¼ logs. So the phase 2b study has been reported in the 2 papers that I mentioned right at the start, and showed that with 2 intramuscular doses in those who were contacts of infectious cases of TB and had a positive IGRA, that's the quantiferon test, golden tube variety, that there was a 50% reduction in subsequent tuberculosis, and this efficacy was greater in those aged 18 to 25 years. They looked at CD4 and CD8 cell expression, but they used the CD40 ligand marker, which is more present on Th2 cells and antigen-presenting cells promoting cytotoxicity. Cytokines measured, as we've talked about before, and then they also measured antibody levels. So this a large study of 26,000 people is planned as a phase 3 trial with 50 trial sites, many of which are going to be in Southeast Asia and in Indonesia. The cost of such a trial is more than $500 million US. But, and people with HIV are going to be included. The plan is based on the fact that with a 50% efficacy, as in the phase 2b trial, there could be significant effects in terms of TB cases, TB deaths, treatment, and costs. From our talk about immunology, there's some useful things that could be done with this study. You could map the CD8 response in terms of granulysin and cytotoxicity and look at the HLA class 1 phenotype of the human individuals as to their response. If TB disease develops, then we should do whole genome sequencing of these strains and see whether these 2 antigens are the same, have the same T-cell epitopes as in the vaccine. It would be good to measure the effect of the adjuvant or the vaccine on NK cells and gamma delta cells producing granulysin. And if there will be prolonged follow-up, so is there similarly a trained innate immunity during the period of follow-up? So in conclusion, BCG is an effective vaccine against first infection, but probably not as effective against post-primary disease. Vaccine immunology for TB is much more complex than for viruses, and we need to look at granulysin, try and reduce tissue destruction, and note that macrophages are able to reduce growth but do not actually kill tubercle bacilli. New vaccines are being produced, and this huge study with the M72 vaccine is about to start. So thank you for your attention.
Thank you, Professor Bartelheim, for your excellent presentation. It's very complicated to understand the whole TB vaccine development. And now we move to the last speaker. May I have the CV, please? Dr. Philip Alexander Ducrot. He is got a Bachelor of Medicine from the Bachelor of Surgery and Fellow of the Royal Australian College of Physicians, Infectious Diseases Specialist in 2004, and Master of Clinical Epidemiology from Monash University 2006, and current employment as a co-head of TB Working Group, Burnett Institute, Melbourne, Australia. Infectious disease specialist in Burnett Institute 2 in Melbourne, Australia. And many prestigious employment positions since 2010. And many publications, about 71 peer review publication, and also many clinical trial already set here as mostly of the multi-drug resistant tuberculosis, I think. And he got an award of Royal Australian College of Physicians International Medal in 2018. And some position in the W Guideline Committee. So the time is yours, Dr. Phillips. Yes, please. Your time is 21 minutes.
So, selamat pagi. Thank you very much to the organizers for having me here to present at the 5th INATIME. It's an honor. I'm going to speak briefly about TB preventive treatment. And next slide. I will try to deal with the issue that we have good detection or good diagnostics for TB. We have treatment that's more than 95% effective, and we have prevention treatment that is 80% effective. Next slide. Yet still more than 10 million cases every year and more than 1.6 million deaths. We have tools we need to use better, and the tool I want to talk about is prevention. Next slide. These are the 5 points that I'm going to make. So if you remember this slide, then I think I've done a good talk. We will test you at the end, so stay awake. Next slide. So prevention and active case finding reduces TB incidence faster than one alone. Next slide. So we know from WHO that we are not on track to achieve the elimination targets. We need to use the tools we have better, and like the previous speaker talked about, we need to develop new tools as well. But the rates of TB is declining only about 1.5% per year, and actually during COVID it went up. Next slide. This is theoretical. If we have a model, this one maybe doesn't reach so far. The red represents a person with active TB, infectious and will spread infection to other people. The grey represents people who are not infected, and the orange represents people with latent TB infection who may become sick in the future from their infection. This represents the standard TB program doing passive case finding. Some people who have active TB will get sick and go to hospital, and then they get diagnosed and treated. But there are many people in the community still transmitting. Next slide. If somehow we could identify everyone with TB and identify all their contacts, test them and immediately treat those with active disease and give prevention treatment for those with TB infection, we could stop transmission. Okay, the real world is not like the theory. We have to find ways of being able to do this better, faster, cheaper. Next slide. TB prevention is not new. We have a 70-year history of using drugs to prevent people with TB infection getting active disease. The good news is the preventive treatment is getting shorter. It used to be 18 months, then 12 months, then 6 months, now it's 3 months, even 1 month. Next slide. I'll just talk about 2 studies. The graph on your left represents work done in Alaska. In Alaska in the 1950s, they had rates of TB much higher than Papua province in Indonesia, more than 700 per 100,000. And they started doing active case finding. But in addition, they did a randomized trial, the first trial of isoniazid prevention treatment. This graph shows the rates of TB infection in children. And within 10 years of active case finding and preventive treatment, the rates in children of infection dropped nearly to 0. Transmission was interrupted. They went back to the communities 19 years later and actually showed that the communities that got prevention treatment and active case finding had much lower rates of TB 19 years later. So preventive treatment is effective now and ongoing. The second graph shows implementation in one large city of household contact tracing and prevention treatment. And you can see that the rates of TB have been reduced, but not maybe as dramatically as in Alaska. You need active case finding beyond the household. Next slide. So I'll move on. We've already discussed. Isoniazid preventive treatment has short-term and long-term benefits for the community. Next slide. So I think this concept for infectious disease of detect or search, treat and prevent is not new. But in TB, we haven't really been doing very much on the search, and we haven't been doing enough on the prevent. Next slide. So TB preventive treatment needs to be scaled up if we are to have impact. We have been using prevention for children under 5, for people with HIV, but this is not enough to have community impact. Next slide. If we look in the yellow square, this represents the 10 million people who have active TB each year. But if we measured everyone in the world for latent TB infection, there would be 1.7 billion people detected with TB infection. Next slide. Which would go on to approximately result in 10% active TB, or 170 million cases. So we need to pay attention to TB infection. Next slide. Treating TB infection prevents TB. So we know from the many randomized controlled trials that TB preventive treatment is 60 to 80% effective. If the person takes all of the treatment, it's more like 80 to 90%. If the person only takes some of the doses and stops treatment, it still has some preventive effect, but much lower. We also know from a review of 13 randomized trials that TB preventive treatment does not result in an increase in resistance in the community. Sometimes we worry too much in TB about generating resistance. Of course, you need to find those with active TB and not give a single drug. But actually, we're quite good at doing this, and we shouldn't be overly concerned that TB preventive treatment will lead to more drug resistance. Next slide. So who should we treat? Well, if we had the right tool, out of that 1.7 billion, we could do a test and just pick the 10% of people with incipient TB, those likely to develop active disease. Unfortunately, our latent TB infection tests at the moment are not good enough to determine which is the 10% of the 1.7 billion. So we need to combine a test like tuberculin skin test or IGRAs. We need to combine that with the individual risk score. So looking at epidemiological risk, has the person been in a household recently exposed? Or do they have immune conditions that increase their risk? And we need to look at balancing the risk and benefits. Next slide. I should say there are a number of tests in development being researched to see if we can have a better latent TB infection test that detects those most at risk. I'm not going to talk about those tests, that's a whole talk by itself, but there will be more data presented at the Union TB conference this year. TB preventive treatment, there are 5 different regimens recommended by WHO. I'm only going to mention 3 that are available or used in Indonesia. So isoniazid 6 to 9 months is still an effective regimen, but when you're over 35, the older you get, the risk of hepatotoxicity increases. So it's also a long duration, and so the rate of completion is very low. It's only about 50%. Shorter regimens have more uptake and much higher completion. In the Zero TB project here in Yogyakarta, the team is achieving 90% completion rate with 3-month treatment. And I think there'll be some presentations in the conference about that later. So 3-month treatment is more acceptable to people, has better completion rates. It has lower rates of hepatotoxicity. You do need to know about the risk of rifampicin hypersensitivity. The risk is low, but the consequences can be serious, and it often presents like a flu-like illness, so it can be hard to diagnose. You need a high index of suspicion. I recently had a patient that we'd stopped rifampicin. We then thought it was something else. We restarted rifampicin, and the poor person ended up in hospital from hypersensitivity. It can be difficult to diagnose. When you have someone for preventive treatment, if you're not sure, it can be safer to not give. Next slide. So, rule out active TB. And here, there's no perfect test to rule out active TB. You need good clinical skill, but over-treatment may be better than under-treatment. Missing cases of active TB is more harmful than over-treating a case of latent TB. Next slide. You've seen this slide already. TB is a spectrum of disease. Maybe at one end of the spectrum, active TB, there are some easy cases to diagnose. Very sick, cough up blood, positive sputum. At the other end of the spectrum, chest x-ray normal, no symptoms, sputum negative, easy to diagnose. But this group in the middle can be more complicated, subclinical TB or incipient TB. Next slide. There's a recent article from The Lancet in 2022 that just makes this point and says, mind the gap. We have the patients, we sometimes, as clinicians, we think in two groups, latent TB, active TB. But remember, TB is not two groups, it's a spectrum. And at the moment, we have this group in the middle, and the algorithms don't necessarily help us. So we need to rely on expert and expertise. Maybe the patient, if they still have symptoms and you're not sure if it's active or latent, maybe you need to take some time and follow the patient. Repeat the chest x-ray. Does it change? Take another sputum. One sputum is not maybe enough to rule out TB. So in Australia, in my hospital, we will discuss once a week the difficult cases because more minds is better than one. Next slide. So number 4, we need systems to safely deliver TB preventive treatment. If there is 1.7 billion people with latent TB infection globally, how many of the population in Indonesia has latent TB? And how many of them need to be treated? I'm sorry, I was lazy, I didn't do the calculation, but there are probably researchers in this audience who know that answer already. You can discuss over the tea break. Next slide. So when we see the individual, we need to think, does this individual have active TB, and rule that out? Does this individual have latent TB? If they have latent TB, are they high risk for developing active TB? Are they high risk for side effects from the medication? And we need to balance the benefit and the risk. And then if we do decide to start treatment, then we need to ensure good education. But we don't need to start treatment on everyone. If you have a 90-year-old who has latent TB infection, 10 other comorbidities, and maybe a life expectancy of 6 more months, maybe giving treatment with isoniazid rifampicin or rifapentine is not in that patient's benefit. If you have a 50-year-old, they have a medication that's a contraindication to rifapentine, you need to weigh the benefit and the risk. So some patients with latent TB infection, you may need to follow them up for 1 or 2 years. But most patients can be given TB preventive treatment, and when they're given treatment, we need to ensure good support, good education, so that they will take the treatment to completion. Next slide. Hepatotoxicity, just to make the point that with rifampicin, it's much lower risk than with isoniazid. And with rifampicin, the risk does not increase with age. But we are giving combination short treatment, so there's still a bit of a risk of hepatotoxicity. Next slide. And as mentioned, a small proportion can develop rifamycin hypersensitivity. Next slide. So how do we scale up TB preventive treatment? Well, we need to find ways of being able to go to the risk groups and test people. So we need to go to households, but we can't just be limited to households. We need to look at other high-risk groups, people living with HIV, but also what about those with chronic renal failure? What about people with silicosis, and other risk factors in particular need to be considered? We need to have simplified assessments. How did we scale up HIV treatment globally? We first worked out how to do it in a small setting. Then we simplified the guidelines and we looked at how we could train people. So instead of having an HIV specialist, we could have a general practitioner. So for preventive treatment, how are we going to train all the doctors in the Puskesmas in all of Indonesia to do this? You can't do it only in specialist hospitals. Maybe we need to shift some of the tasks from the general practitioners to the nurses, because otherwise the general practitioners are already busy with lots of other tasks. They can't do all the education and follow-up. We need to think about simplified systems that can be scaled up. And then those systems need to ensure safety. So we need to have good monitoring to know whether there is likely toxicity and that people can stop treatment. But more important than doing blood tests is educating the patient. If you are feeling sick and you're getting pain in the tummy or you start to vomit and keep vomiting, stop the drugs. It's a prevention treatment. It's safer to stop if there are side effects. So good education is more important than monitoring tests. Next slide. So I'm not going to go through all of the principles, but Indonesia has already learned how to scale up HIV, how to scale up TB treatment, how to scale up drug-resistant TB treatment. The lessons from that can be applied to preventive treatment, simplification, community engagement. How can we engage with cadres so that they can help take away some of the tasks from nurses and doctors? How can we involve key stakeholders? How can we shift tasks? How can we help patients to have good education and understanding? Next slide. And finally, we need to treat contacts of drug-resistant TB. Next slide. So in a meta-analysis of 25 studies, they showed that household contacts with drug-resistant TB, that nearly 7% developed TB over a 3-year period. And 47% of the contacts had latent TB infection. Next slide. Just an example, in a small island in the Pacific, they had an outbreak of some drug-resistant TB cases. So they offered people who were contacts preventive treatment with fluoroquinolone-based treatment for 6 months. For the over 100 people who were contacts who took the treatment, none of them developed MDR-TB. Of the 15 contacts who refused treatment, 3 of them developed MDR-TB, and there were another 15 who developed MDR-TB who they had not found and been able to offer treatment. This is just one example. At the Union Conference later this year, there will be 2 randomized trials on levofloxacin preventive treatment for MDR-TB that will be presented, the TB CHAMP and the VQuIN study. Next slide. And there's also a study looking at delamanid for preventive treatment, which compares delamanid versus isoniazid. Next slide. So, in conclusion, no surprises from my conclusion, the same 5 points. Prevention should be added to active case finding and scaled up. We need to scale it up to achieve impact. First, you need to rule out active TB disease, but over-treatment of patients is better than under-treatment. We need systems to safely be able to deliver and monitor scale-up. And we should treat contacts for drug-resistant TB. Thank you. Terima kasih.
Thank you, Dr. Phillips, for the excellent presentation. Yes, for this session, we have no question and answer. You can meet the expert after this session in the break time. And unfortunately, Dr. Andaru already left because he should be go to Jakarta. And maybe only one speaker here. But you can meet Dr. Phillips after this session. I want to make a short summary for the first presentation. Dr. Andaru already explained about the incidence, risk factors, and also TB transmission, strategy of the end of TB, and also the important thing is surveillance. Surveillance is also a very important task to TB elimination. And the national regulation by the Director General of Medical Services in 2021, they have the TB infection control program, contain of administration of measurement, environment, and also personal protective of measurement. And also, she explained about the program, TB program in Dr. Sarjito Hospital. I think it's very important one, that the early finding new patient and separated the patient from the other non-TB, and also give the right treatment. Important thing also the infection control to prevention. They have triage, education, separate, use the mask, and also education. And the last one, the important also that in Yogyakarta there is screening TB for the health worker. They will be regularly done. And from Professor Graham, he explained about the BCG. BCG actually is still effective for primary TB, but less effective to the post-primary TB. And he also explained about the innate immunity and the trained innate immunity. And we can see also the response of the T-cell responses is still good up to 18 months, but don't know after 30 years it's very low. The other important thing is about the importance balance system. Here for the pro-inflammatory system, tissue repair, and also regulatory. And the role of the NF-alpha and other cytokine is also mentioned. And the other one is the new TB vaccine. TB vaccine, the new one is divided by two types, the preventive and also for the therapeutic. And we know that the whole cell inactivated and subunit vaccine is on the pipeline with the pro and cons. And other one, the Professor Graham also mentioned about the last vaccine, TB vaccine, M2072. Already done the phase 2 and now ongoing on phase 3. And I think it's more challenges to waiting the result of the phase 3 trial, including in Southeast Asia and Indonesia, including in this study. From the Dr. Phillips, please correction me if wrong. He told about the 5 points. The first was a TB elimination. That the latent TB, if not treated, it will be active TB and transmitted occur among to the community. And if we treated the TB, latent TB, it will stop the transmission. It's very important. And the second one is TB, treating TB, but we can see that for preventive, it's reduced about 60 to 80%. It's quite high. But the important thing is there is no test prediction for prediction progression to the disease. And we can see that from the prevention, we have firstly 6 to 9 months, and that still used in Indonesia with the isocyanide, and 3 months rifampicin and iso, also 3 months weekly rifampicin and iso. But there are advantages and disadvantages of the schedule. And also the third one is rule out of TB disease. He said that over treatment is better than under treatment. And the other one is the safety of the toxicity of drug. And the last one about the treatment of contact exposure MDR-TB. I think this is a short summary of the 3 excellent speakers. And please, big applause to all speakers. Thank you so much for your attention. Assalamualaikum warahmatullahi wabarakatuh.